A headache or cephalalgia is pain anywhere in the region of the head or neck. It can be a symptom of a number of different conditions of the head and neck. Headaches can result from a wide range of causes, both benign and more serious. Brain tissue itself is not sensitive to pain, as it lacks pain receptors. Rather, the pain is caused by disturbance of the pain-sensitive structures around the brain. 9 areas of the head and neck have these pain-sensitive structures, which are the cranium, muscles, nerves, arteries and veins, subcutaneous tissues, eyes, ears, sinuses and mucous membranes. There are a number of different classification systems for headaches. The most well-recognized is that of the International Headache Society. Headache is a non-specific symptom, which means that it has many possible causes, including fatigue and sleep deprivation, stress, the effects of medications and recreational drugs, viral infections and common colds, head injury, rapid ingestion of a very cold food or beverage, dental or sinus issues, and many more. Treatment of a headache depends on the underlying cause, but commonly involves painkillers. Some form of headache is one of the most commonly experienced of all physical discomforts. Cause. There are more than 200 types of headaches. Some are harmless and some are life-threatening. The description of the headache and findings on neurological examination determine whether additional tests are needed and what treatment is best. Primary versus secondary headaches. Headaches are broadly classified as primary or secondary. Primary headaches are benign, recurrent headaches not caused by underlying disease or structural problems. For example, migraine is a type of primary headache. While primary headaches may cause significant daily pain and disability, they are not dangerous. Secondary headaches are caused by an underlying disease, like an infection, head injury, vascular disorders, brain bleed or tumors. Secondary headaches can be harmless or dangerous. Certain red flags or warning signs indicate a secondary headache may be dangerous. Primary headaches. 90% of all headaches are primary headaches. Primary headaches usually first start when people are between 20 and 40 years old. The most common types of primary headaches are migraines and tension-type headaches. They have different characteristics. Migraines typically present with pulsing head pain, nausea, photophobia and phonophobia. Tension-type headaches usually present with non-pulsing, band-like pressure on both sides of the head, not accompanied by other symptoms. Other very rare types of primary headaches include cluster headaches, short episodes of severe pain, usually around one eye, with autonomic symptoms which occur at the same time every day. Cluster headaches can be treated with triptans and prevented with prednisone, ergotamine or lithium. Trigeminal neuralgia, shooting face pain, hemicrania continua, continuous unilateral pain with episodes of severe pain. Hemicrania continua can be relieved by the medication Indomethacin. Primary stabbing headache, recurrent episodes of stabbing, ice pick pain, or jabs and jolts for 1 second to several minutes without autonomic symptoms. These headaches can be treated with Indomethacin. Primary cough headache starts suddenly and lasts for several minutes after coughing, sneezing or straining. Serious etiologies must be ruled out before a diagnosis of benign primary cough headache can be made. Primary exertional headache, throbbing, pulsatile pain which starts during or after exercising, lasting for 5 minutes to 24 hours. The mechanism behind these headaches is unclear, possibly due to straining causing veins in the head to dilate, causing pain. These headaches can be prevented by not exercising too strenuously and can be treated with medications such as Indomethacin. Primary sex headache, dull, bilateral headache that starts during sexual activity and becomes much worse during orgasm. These headaches are thought to be due to lower pressure in the head during sex. It is important to realize that headaches that begin during orgasm may be due to a subarachnoid hemorrhage, so serious causes must be ruled out first. These headaches are treated by advising the person to stop sex if they develop a headache. Medications such as propranolol and diltiazem can also be helpful. Hypnic headache. Moderate severe headache that starts a few hours after falling asleep and lasts 15 to 30 minutes. The headache may recur several times during night. Hypnic headaches are usually in older women. They may be treated with lithium. Secondary headaches. Headaches may be caused by problems elsewhere in the head or neck. Some of these are not harmful, such as cervicogenic headache. Medication overuse. Headache may occur in those using excessive painkillers for headaches, paradoxically causing worsening headaches. More serious causes of secondary headaches include meningitis, inflammation of the meninges which presents with fever and meningismus, or stiff neck, bleeding inside the brain, subarachnoid hemorrhage, ruptured aneurysm, arteriovenous malformation, intraparenchymal hemorrhage, brain tumor, dull headache, worse with exertion and change in position, accompanied by nausea and vomiting. Often, the person will have nausea and vomiting for weeks before the headache starts. Temporal arteritis, inflammatory disease of arteries common in the elderly with fever, headache, weight loss, jaw claudication, tender vessels by the temples, polymyalgia rheumatica, acute closed-angle glaucoma, headache that starts with eye pain, blurry vision, associated with nausea and vomiting. On physical exam, the person will have a red eye and a fixed, mid-dilated pupil. Pathophysiology. The brain itself is not sensitive to pain, because it lacks pain receptors, also called nociceptors. However, several areas of the head and neck do have nociceptors, and can thus sense pain. These include the extracranial arteries, middle meningeal artery, large veins, venous sinuses, cranial and spinal nerves, head and neck muscles. The meninges, phalanx cerebri, parts of the brain stem, eyes, ears, teeth and lining of the mouth. PL arteries, rather than PL veins, are responsible for pain production. Headaches often result from traction to or irritation of the meninges and blood vessels. The nociceptors may be stimulated by head trauma or tumors and cause headaches. Blood vessel spasms, dilated blood vessels, inflammation and/or infection of meninges and muscular tension can also stimulate nociceptors and cause pain. Once stimulated, a nociceptor sends a message up the length of the nerve fiber to the nerve cells in the brain, signaling that a part of the body hurts. Primary headaches are more difficult to understand than secondary headaches. The exact mechanisms which cause migraines, tension headaches and cluster headaches are not known. There have been different theories over time which attempt to explain what happens in the brain to cause these headaches. Migraines are currently thought to be caused by dysfunction of the nerves in the brain. Previously, migraines were thought to be caused by a primary problem with the blood vessels in the brain. This vascular theory, which was developed in the 20th century by Wolff, suggested that the aura in migraines is caused by constriction of intracranial vessels, and the headache itself is caused by rebound dilation of extracranial vessels. Dilation of these extracranial blood vessels activates the pain receptors in the surrounding nerves, causing a headache. The vascular theory is no longer accepted. Studies have shown migraine head pain is not accompanied by extracranial vasodilation, but rather only has some mild intracranial vasodilation. Currently, most specialists think migraines are due to a primary problem with the nerves in the brain, or are thought to be caused by a wave of increased activity of neurons in the cerebral cortex known as cortical spreading depression followed by a period of depressed activity. Some people think headaches are caused by the activation of sensory nerves which release peptides, such as serotonin, causing inflammation in arteries, dura and meninges and also cause some vasodilation. Triptans, medications which treat migraines, block serotonin receptors and constrict blood vessels. People who are more susceptible to experience migraines without headache are those who have a family history of migraines, women, and women who are experiencing hormonal changes or are taking birth control pills or are prescribed hormone replacement therapy. Tension headaches are thought to be caused by activation of peripheral nerves in the head and neck muscles. Cluster headaches involve overactivation of the trigeminal nerve and hypothalamus in the brain, but the exact cause is unknown.